So yeah, my funny story would be when I was in college, I went visited my friend who was studying abroad in London, and I almost got kicked out of a pub because they thought I was so intoxicated that I had passed out at the table. But really, I had just put down my head for a quick nap, and my friends were like, "No, he has to sleep this door. Don't kick him out." And so that's something I look back on in the laughing way, because my friends had my back in terms of protecting me during a sleep attack.
Yeah, I love that. A good support group when they have your back is very helpful. You made me remind me of one time I was on an airplane and couldn't wake up. I was having sleep paralysis and I couldn't wake up, and the flight attendants kept trying to wake me up, and they ended up having to call security, and they were getting ready to arrest me. And then I finally, after I was able to come out of it, they finally let me go. But I just could not wake up to get off the plane. They're like, but anyway. Anybody have any questions about medicine? So I'll just talk about medicine, because it took me a long time to find my medication, and I've had this for so long. But I tried Xyrem back when it first came out, and wasn't prescribed properly because my doctor didn't know what he was doing. And then I went to a guy who had a lot of people with narcolepsy on Xyrem, and then I've been on it ever since. And it was, totally changed my life. And I had tried lots of different medications, and now I'm also on a new one, Sunosi, which is incredible. I can stay awake all day long without a nap, and I still take naps though, but I can stay awake all day long, and it makes my brain sharp and I think way better. So be open to trying medications.
It is kind of funny how many other sleep providers aren't familiar with oxybate products. It's kind of like I'm not surprised that I heard that someone would have to hear about an oxybate from their peers rather than from their doctor, but it's the current state of it. I think it's going to get better as this is more established medication. It's part of the guidelines of care. But it is still something that you still have to ask about, because they may not be familiar with it. And I know some people, you may live in an area where there's only one sleep doctor in a 30-mile radius, and they're really just a regular pulmonologist. They'd rather be taking care of a person in an ICU, but they also manage CPAPs, and they may not know about oxybates, or they only heard about it a little bit, and they feel it's too messy for them to deal with, and that's the unfortunate reality that we live in right now. But it's important to ask and advocate for that, even if that's your only provider, and kind of if you can't provide it, you need to connect me with someone that can. So the question was, given that narcolepsy is a neurologic disorder, how does this correlate with dementia or Alzheimer's as we get older?
Easy. It doesn't. So to expand on that, it has absolutely nothing to do with dementia. You may feel like your memory is worse, and you may feel like it's very difficult to go on, and so on and so forth. It has got nothing to do with dementia. It doesn't predispose you to having dementia. It doesn't mean you're more likely. It also doesn't mean you're less likely. So if you're going to get it, you're going to get it. Narcolepsy has nothing to do with it.
Question right there.
As a mental health therapist myself, it's really important to have that integrative care with. Thank you. As a mental health therapist myself, it's really important to have that integrative care between providers of different disciplines and seeing the results as a byproduct of that. I'm curious, as two individuals in very different fields than my own, what do you see as the largest barrier for integrative care, and how do you guys go about attacking that barrier to help for patient care?
So I think some of it is that a lot of the, at least for me as a pediatric provider, who many of my narcolepsy patients, they come to me already with diagnoses of depression or anxiety, and they're already on medications. But the provider they see is in a different health system where it's very hard for me to get in contact with. Their therapist is in another organization that I don't know how to get in touch with, or they don't even have a therapist because there's no coverage for that on their insurance plans. And so I think that is like the fragmentation of the care is kind of gets in the way of a true multidisciplinary care. My ideal practice would have all, like, everyone involved under the same clinic visit. Unfortunately, that's very hard to do even in the largest academic centers. And so when I see my patients, they get established with me and they get established with a diagnosis, I bring them, say, it's great that you're already seeing a psychiatrist to manage your depression, but are you seeing a therapist? It's like, we used to see one, but we didn't like it, so we stopped. So, well, you need to find someone, and let me know who they are once you're connected, because this is something that you can't really do without. And it's better to establish care right now when you're not having like a catastrophe going on, and then to be able to connect with them if something happens, then try to find one while you're dealing with an emergency.
Yeah, integrating care is obviously very important, and to the extent that you can, keeping your care within one health system certainly helps. Though, with the healthcare regulations that have happened over the last 15 years, there is movement towards integrating healthcare records. For example, in this area, healthcare records between Duke and UNC are shared. So I can see what happens at UNC, they can see what happens at Duke. It's obviously a microcosm of what is going on in the country, but I can also see records from Atrium, not Atrium anymore. Novant, Atrium, whatever. I mean, the larger centers in the Charlotte area. So some of that's happening. Now, there are obviously smaller practices, private practices that we don't have access to their healthcare records, and that is indeed a problem. But at the end of the day, the thing to remember is, as many of you have pointed out, you are your own best advocate. And you cannot rely on others to be your advocate. You're going to have to be your own advocate. And if you feel like your medical history is not fully understood by one of your providers, then it behooves you to make them understand.
Thank you.
All right, so how about red, black, blue? I'm going by shirt color.
Yeah. Something we discussed a lot today was common misperceptions and myths, and a lot of struggles in the diagnostic process. Are there any misperceptions or myths that you see more common in the clinical setting from physicians that you don't think are as mentioned when we talk about myths and misperceptions you see from the general public?
Yeah, so from the pediatric side, I think it's a lot of misattributing to sleepiness to like a poor sleep schedule or not getting insufficient sleep, and that's like the biggest barrier I have to deal with to trying to tease it apart, because sometimes that's the reality. They are not sleeping enough. I do the actigraphy, and it's like, why is the lights red, green, and blue on all the way up until 2 a.m. when lights are off? So I can the device I use it's called an actigraphy. It tracks your movements, lets me know if you're awake, laying in bed awake, or asleep. It also has a light sensor, and I can tell if you're using an electronic device or not. And sometimes, yeah, that's the case. But sometimes it's, do you have sleep fragmentation? You're just like, your sleep schedule is so irregular because you're going to sleep at all these different times. Is that what's going on? And I've seen that too. And I feel that sometimes that delays the diagnosis that the initial provider, primary care doctor, says it's just you're not sleeping enough. You need to work on your sleep schedule. A month later, or 2 months later, you're still not sleeping right. I'm not going to do anything for you. Next child check next year, it's still going on, and that's the buck gets passed down further and further down the line. And meanwhile, problems start developing. School issues, social issues, and it just keeps. And that's one of the things I think that misconceptions about how narcolepsy is, especially if you have good ways of compensating for it. You can mask being awake. You do well enough in school not to cause any waves. That pushes things back. It still causes issues with you, with your thoughts and self-worth. But it makes it difficult to get your foot in the door into getting diagnosed.
Yeah. No, I agree with everything that Dr. Ortiz just said. Talking about myths and misconceptions, I mean, my whole presentation was on that, and I think the biggest for me is just getting to a diagnosis. I think there are so many people who don't get the correct diagnosis for whatever reason. I think one of the biggest issues is that even within the field itself, I remember a number of years ago, the folks at Jazz Pharmaceuticals did the survey of sleep physicians and asked them to fill out a questionnaire of what are the symptoms of narcolepsy. And in medical school, we were taught there are four cardinal symptoms of narcolepsy.
If we're taught.
If we were taught, but really it's 4 cardinal symptoms of narcolepsy. People argue maybe it's 5, but 4 cardinal symptoms of narcolepsy. Only about, I think, 60% of sleep physicians came up with those 4 symptoms. 60% of sleep physicians came up with those 4 symptoms. So that kind of gives you an idea that you go to a sleep clinic, you go for a diagnosis, and you come back empty-handed. You may not have gotten the opinion that you really deserved. The other is the MSLT, and I talked a lot about that. I've talked to people afterwards as well. And someone, I think in today's session, talked about having cataplexy and having a negative MSLT. What do you do with that information? You have cataplexy, but you're being told you don't have narcolepsy. How does that make any sense? And so as a physician, I got to take those 2 pieces of information and come to terms with it. And one thing has to be right, the other thing has to be wrong, and I have to decide which one is right and which one is wrong. Most of the time, it's going to be the patient's always right. And so these are things that I think are big issues in the field that don't have correct solutions to. The other is our own guidelines. Our own guidelines say that you got to have a positive test. One of the things that I often talk to people about is, when you go to a psychiatrist and you got depression, they talk to you, they come up with a diagnosis of depression. What test did you get? Did you get an MRI? Did you get a blood test? Nothing. You got a conversation and you came home with a diagnosis, but that cannot happen with narcolepsy. You can't come home with a diagnosis after having a conversation. And we don't have a great test for it. So I think these are some of the big issues. The other is someone will tell you, okay, you've got narcolepsy. We're going to start you off on Adderall or Ritalin or maybe Provigil because these are sort of the milder medications. Let's start you off on those and not the big guns, the oxybates. We're going to hold those off till you really need them. But what's the sense in that? When are you really going to need them? When you're old? As opposed to when you're young and in school and need to figure out what you're going to be in life? And so, why would you withhold a medication that's really effective? Yes, very potent, of course, potentially dangerous if you abuse it, but I'd say that's true with just about every medication. If that's going to change your quality of life drastically. And, I was involved in the initial clinical trials before Jazz Pharmaceuticals. It used to be Orphan Pharmaceuticals that were doing clinical trials on this date rape medication. It was commonly referred, perhaps some of you have heard of the date rape medication. That's what oxybate was. And that's how people thought of it. And before I prescribed it, once it became available, I always talked about date rape and the fact that it made no sense for patients who had narcolepsy, because obviously they weren't going to give it to themselves for date rape purposes. And so none of that made any sense. So it had to be talked about. But to withhold that, thinking that's a date rape medication, you don't really need it right now, your narcolepsy's got to be a lot worse before you, that's all nonsense. So you really got to advocate for yourself, get the best medication. And there's many out there now, thankfully, but you still have to advocate for yourself.
So I think her and then...
When you talk about consistency of medications, importance of take your medications, what advice do you have when inevitably you get a respiratory illness or cold and flu season roll around? An example being I found 2 medications that worked really well for me, and I was doing well at my job working with lots of little kids. Then suddenly I was getting sick all the time, and when I had a cough, it was recommended to me, hey, don't be taking certain medications. So I was forced into breaks. But every time, like let's say it's a pneumonia, a cough, if you need to take Sudafed, the recommendation I was getting is stop taking your meds. And even coming back onto it in the recovery process, maybe stimulants were giving me heart palpitations, and it just felt like, yeah, I took a couple days or weeks off for PTO just for the pneumonia, but then it was another week or 2 of getting back used to my oxybates and my medications. So I just get very nervous when flu season rolls around and just wondering what's best practice with staying consistent when you're also told don't be taking those medications when you're going through respiratory stuff.
I could answer that, but it'll be completely politically incorrect. But so I'll let Dr. Ortiz go first.
Yeah, you work with kids, when they.
I don't know. It's just
sick.
it kind of like I would just say just don't take the I know. I'm just more like continue taking the oxybates and just avoid the sedating meds, and it's going to be tough. But I don't know. It's just it feels that there's no right answer for this. But it kind of depends on what your values are and what your tolerance for risk is as well. Obviously, I'm not going to recommend that you do something that's like overtly dangerous. But so basically, like if it's like if you're not taking a whopping dose of Sudafed, then that might be okay. But if you're saying like, yeah, I always have to take like the full recommended dose every time, it's like, okay, we might have to slow down on the oxybate. Maybe there's a role for a lower dose when you're sick, but it's something that you have to like kind of make up a plan, especially if you get sick regularly of what you do. But I think I don't think stopping your meds is going to be helpful for you at all in the long run. And of course, there's always the issue of like, if you get vaccinated against the flu every year, because you obviously you're worse off if you do get these issues. I really want to hear this non-PC answer though.
So the oxybates used to be very easy to prescribe. So I'm going back to around 2005, 2006, and around 2006 or 2007, a report came out from Jazz Pharmaceutical that 20 patients who were taking oxybate or some number, I think 10 or so, died. And this was a big deal. Patients died taking oxybate. And so what happened? You went back and looked at the data, and it turns out that these patients were also taking narcotics. They were also drinking alcohol heavily, and I don't mean a small dose, substantial doses of narcotics. And so this was very concerning. And so Dear Doctor letter, I mean, you're familiar with Dear Doctor letters. You guys may not be. When something bad happens, we get a Dear Doctor letter from the company. And so it's always a big deal. The companies go through a lot. It's financially very draining for the company to send these Dear Doctor letters. So we got Dear Doctor letters from Jazz Pharmaceuticals, and I forget if it was Orphan at the time or Jazz, whatever. And so that really put a hamper on how we were prescribing this, and that really changed something that you guys are very familiar with if you take oxybates. That's the central pharmacy. And the central pharmacy, and we've got members from pharma here as well, but the central pharmacy is tough to deal with from your end and from our end. If you tell them that you started taking Tylenol, they'll tell you to stop taking sodium oxybate. So you can't tell them anything. I didn't mean that. You should tell them what you're taking. But when you tell them what you're taking, the immediate answer is going to be, don't take your oxybate. Having said that, I also treat a lot of people who have something we haven't talked about today, and some people have mentioned it without calling it what it is, and that's REM sleep behavior disorder. REM sleep behavior disorder is when you act out your dreams. So some of the things that people have talked about, jumping out of bed, running away from whatever nightmare or dream that they were having, that's REM behavior disorder. What happens in REM behavior disorder, just sort of as a side, REM behavior disorder is when you go into REM sleep And instead of being paralyzed, you're not paralyzed, which is a real bad thing, because when you are in REM sleep and you're not paralyzed, you will do what you're dreaming of. If that's running away from something or jumping out of something, that's what you're going to do. If you think about it, REM sleep behavior disorder is the inverse of cataplexy. Cataplexy is when you get this muscle weakness while you're awake, when you get the REM weakness, but you're awake when you're not in REM. Here, you're in REM, but you're not weak. You're not paralyzed. So it's the opposite of cataplexy during the day. You get REM behavior disorder at night. So the best treatment for REM behavior disorder now is melatonin, but previously it used to be clonazepam. It still is the most effective drug for REM sleep behavior disorder, and many people who have narcolepsy will also have to take clonazepam to control this REM sleep behavior disorder. And that absolutely is a no-no with sodium oxybate, because it's a benzodiazepine, it's a sedating medication. I have a bunch of people who take both.
Yeah, my follow-up is how to differentiate between when the pharmacy's just being careful and saying no, 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 how we patients know what's a hard no and what's a
That's
maybe.
When you talk to your physicians,
Okay.
and hopefully they have the experience of telling you that, you know, it's okay to take the Sudafed, take it a few hours earlier, this, that, and the other, and then take your sodium oxybate. And that also goes with alcohol. I mean, do I tell my patients never to have an alcoholic beverage? No. I mean, if you're going to drink heavy, then certainly don't. And you can do that. I mean, you know, I've got a bunch of college students who take oxybate. I'm under no illusion that every Friday and Saturday night is going to be dry. And so if they're going to drink, okay, just have the sense to not have oxybate that night.
Okay. Do you know if there's any danger of waking, you know, when you're sick and you're like coughing all night, if you take an oxybate but your body wants to cough, what happens? Are you brought out of that deep sleep to cough?
It again depends on the individual. It depends on the cough, how bad it is, and how much oxybate you've taken and what other medication you're taking. Is there a one-size-that-fits-all answer? No. In both directions. So from the central pharmacy direction, the answer is always no, and it's also not always yes either. So it just depends on how sick you are and whether you should do it or not.
Okay, thank you.
So, Dr. Ortiz, you mentioned in one of the first answers you gave to not be afraid to take the new medicines. For a patient who's taking amphetamines or other medications that you can't just stop cold turkey without having, you know, major side effects during the day, how would you recommend them going about switching to one of those heavier, more modern medications?
More modern. Well, sometimes especially like, let's say like pitolisant has, you know, it may be up to 8 weeks before you start appreciating the effects. I sometimes just keep them on what they're on right now until we start approaching week 8. And so it might be the follow-up appointment might be in week 6. And I say, how are you doing? Oh, I'm doing better. And it's like, okay, maybe let's go down by half of what you're doing. And then like a follow-up in a month. How are you doing now? It's like, oh, I'm still doing good. So, and sometimes, you know, sometimes the patients say, yeah, I've already stopped the original medication, or it's like, or I think I'm ready to go down, and that's how I do it. It's like it's based on how well you're feeling, you're managing. Like, and I think like the amphetamines and methylphenidate, I'm less concerned about going cold turkey. But then we have SSRIs and then that's something, it kind of depends on who's prescribing it. If I'm prescribing it, then it's like a gradual wean. And if it's a psychiatrist that's been prescribing it, I kick it back to them. It's like, I tell them, I don't think, like, now that you've been on this, how many, like, you're not having any more cataplexy, you're on this new medication, like pitolisant or oxybate, you're not having any more cataplexy? It kind of depends. Are you taking this medication for anxiety, depression, or are you taking this for cataplexy? If you're taking it just for cataplexy, I'm going to recommend that you start going off, because I feel that you're no longer getting a benefit for a medication. Once you stop having a benefit for a medication, you're just exposing yourself to risk from side effects, and it's time to start going down on that medication. If the benefits already that you previously were getting are no longer there or are being served by the newer medication.
Hey, my question is for you, Dr. Ortiz, because I laughed because I'm a mental health clinician, and I was diagnosed in graduate school because I'll go back. We had literally one class on sleep disorders, and narcolepsy was just one of those disorders. It was mostly about insomnia. And I was like, well, I think I may have this. And I actually got diagnosed at Strong Hospital, and the doctor was like, you probably don't have narcolepsy, but, long story short, 14 years later, I have narcolepsy. But anyway, my question is, I've started to become more of an advocate and speaking out as a mental health clinician about sleep disorders. And how do you balance talking to other clinicians? Because I feel like we are really bad at sleep, and then and learning about sleep generally in our clinical practice. I feel like I've reached out to several schools and be like, I'm a person with narcolepsy. I would like to talk about this as a practicing clinician, and it's like little traction. So it's good to see that you're doing it, and that But how do you do that?
Yeah, and it's really important because like teachers and primary care doctors, pediatricians, they're the gatekeepers for actually getting in with a sleep specialist. And I know that where I work out, we do a lot of advocacy and reaching out to like the county school system. We bring in teachers and do like educational topics on various things, not just sleep disorders, but like sickle cell, or if you have other medical issues that may pop up with great frequency within your population, like what do you deal with? And I think the focus would be that sleep in general is kind of like a mysterious and sexy topic for a lot of these people. And you got to start off just sleep in general, not just narcolepsy, because what are they going to see? They're going to see sleepiness, and they're going to need to think about, are they getting enough sleep? And then also, like, what are the consequences of their student or patient acting excessively sleepy? And so the point is that they shouldn't be in charge of, they're not going to be in charge of diagnosing the narcolepsy. That's going to be the sleep specialist. But they should be mindful that, is this abnormal? Yes, no. And then don't try to like solve it completely on your own. Get referred to the sleep specialist. And so I think like if you're approaching teachers, you kind of focus on the academic outcomes of not getting enough sleep or being sleepy in school. If you're talking with the general pediatrician population, it's more about like, this is what you do to screen for abnormal sleep problems, whether or not they're narcolepsy or not. And this is how long you wait before you refer. And the answer is not very long, because either if it's not a big problem, it's going to correct itself in a short amount of time. If it is a problem, you don't have enough time to work on this, and you don't have the, I don't want to say you don't have the expertise. They should have enough expertise to diagnose it, but you're busy with a lot of other things, and you need to send them to the specialist. And so that's how that's how I feel like the framework should be with addressing these, not directly medical fields, but fields that deal a lot with people who are at risk for sleep disorders like narcolepsy. It's like, it shouldn't be as hyper-focused on narcolepsy, but on general sleep health. And that would make a big difference. And I think I've talked about like, it may be important to like address other organizations that deal with those populations, like teachers groups or nursing associations, because they're going to be the ones to notice it, and they need to like learn how to advocate for their students or charges.
Thank you for all this great information. It's been very helpful. For my own self, how disruptive is getting up to go pee multiple times a night? Because of several things, my work, and also just when I'm thirsty, my ADHD, I tend to just find it easier to just drink a whole bunch of water at night, but that means I have to get up to pee several times. Is that really not helping me? Should I investigate trying to work around this issue?
Not helping you, especially if you're taking an oxybate. Like I literally, I think just like this week, I've had one patient say, like, yeah, I had to get up and go to the bathroom in the middle of the night and I fell. And it's like, okay, we need to like be mindful of that. And so that could be dangerous. But getting enough water is also important. I think studies shown just like even like being a slight little bit of dehydration is still like your brain function doesn't, you're not working at 100% anyways, and that's even if you don't have narcolepsy. And so it's kind of working on trying to, like I said, you need to drink water. That's a problem if you drink water too much right up before bed. So we got to work around it. What kind of solutions? How do we break this down into an answer that doesn't involve something too complex? And so,
but it is worth investigating that
Yeah.
because it is disrupting my sleep enough. Okay, great, awesome, thanks.
I don't know if this is something you can answer in this platform, but it's a question about using other medications off-label to give the same effect as oxybates do. Because I have been taking medication to help me stay asleep, but it doesn't necessarily help me get into deep sleep. And I've managed, my sleep cycles have changed because of the other lifestyle changes that I've put in, but not necessarily because of the medication. It just helps me to stay asleep. So in essence, I'm taking it for the side effect because it's not actually a narcolepsy medication, it's not an oxybate, but it works to help me stay asleep because I'd had struggles with insomnia. So when I was just going around the tables, I was mentioning to some of the people there that most of the medications that people have access to, I can't even dream of having because of where I live, because it's just so expensive. But are there alternatives that can be used? I'll give an example. I started off, the first stimulant I was prescribed was methylphenidate, and I was using the Ritalin form of it, which is the immediate release. I had real issues with it because it affected my appetite and just the waves. And my neurologist suggested that I try to move and use Concerta. I didn't manage to get that because no one was licensed to import it in my country. So I ended up moving to modafinil, which is also sometimes an issue getting because sometimes I get 15 days dose and then have to go back for the rest. So just navigating the issues to do with availability and then cost is the real issue for me. And so hence my question about the oxybates.
So I think one of the most common ones as like the alternative, sometimes baclofen, but I think any like studies that looked at it in terms of improving daytime wakefulness is not really panned out. And I think there was like once, I went to a conference like this where like the speaker was like, how many people have tried out baclofen before? Actually, why don't we do this now? How many people have tried baclofen before? No, well, during this situation, it was like a whole bunch of hands came up, and then like, how many people felt that it improved it? And like 99% of the people dropped their hands. And so, unfortunately, it may help with, and some people do claim that it does help with their sleep continuity. In my practice, I use it very rarely, but even then, I haven't really seen a big benefit from it. But I don't know if Dr. Husain has more experience.
I agree. I think the challenge here is to think of oxybate as simply something that's putting you to sleep and you're getting deep sleep and that's fixing the problem. That may be it. We have no confirmation that that's why it works. When you look at the studies, and recent ones have also sort of re-demonstrated this, that at a full dose of oxybate, of sodium oxybate, you get about an hour extra of deep sleep. That's great. But is that what's really making you more awake during the day? Is that really what's getting rid of the cataplexy? I don't know, it may be. And so baclofen, yes, it increases the amount of deep sleep, but not by that much. And we don't know if deep sleep is really what's doing it. There are other drugs like gabapentin, for example, that also increases deep sleep. That kind of also sort of helps, but we don't, again, know what effect it has on daytime alertness. I have prescribed gabapentin for a lot of different things. Most sleep physicians do. Restless leg syndrome comes to mind as a condition where we prescribed a lot of gabapentin. Patients come back to us, they feel better, but they feel better because they're restless legs get better, they're not all of a sudden much more awake during the day. Again, they don't have that problem to begin with. So no, that data isn't out there. Is it okay to try it? I suppose if you've got no other alternative. We do things off-label all the time. But to think that will be comparable, I think that's maybe not accurate.
And I totally get where you're coming from. Like, so when I was diagnosed, this was before the Affordable Care Act. So the health insurance I had did not have a medication coverage. It did not cover. I could see I can see any doctor I wanted, but I did not cover any medication. So I had to learn how to like stretch some of the medication sometimes, and so that may involve if you only get 15-day supply. Fortunately, with modafinil, you can cut them in half, and sometimes you gotta do that to make it stretch because some improvement is better than no improvement sometimes. And it's not a fun situation that you're in, and but yeah, it's tough when there are medications out there, but you don't have access to them.
Well, thank you.
Also remember that not being approved by the FDA for an indication doesn't mean it doesn't work. And so, many of these medications, modafinil included, technically not approved for idiopathic hypersomnia. Really, nothing is approved for idiopathic hypersomnia. That doesn't mean we don't treat it.
And then, if you have other medical issues, like you said, like you're using the side effects. And so I sometimes do that as well. I mean, granted, for my insomnia patients that I see as pediatrics, anxiety, depression, well, they get put on trazodone because that's going to help their anxiety, depression, but that makes them sleepy. ADHD, I put them on clonidine, makes them sleepy. Next day, their ADHD symptoms are improved. And so sometimes it is talking about the whole picture to see if we can help one other aspect of your life while still taking advantage of the side effects of that medication.
Yeah, I guess for me it's just the balancing act, because when you start thinking about taking something long term that is not, you're taking it for the side effect rather than the initial, then you start to wonder, is it really okay? But then you think, is it better for me to keep taking it so I can maintain a level of sanity or try something else? So that's
getting a good enough sleep is a big quality of life issue, and you're right. It may not help your sleepiness, but it may help your sense of self and sanity, and that's a good enough reason to continue it. Especially if you're not feeling like you're having any adverse effects from that, and you're following the directions of a doctor who's monitoring you for any potential risks.
Thank you.
Before you get to the next question, one correction. There are drugs approved for idiopathic hypersomnia. I knew I was going to get corrected, so before someone else corrects me, I'll correct myself.
So if the MSLT is not very reliable for diagnosing narcolepsy or IH, how can we get that changed from a requirement to where you can diagnose more authoritatively for the insurance companies and not have that be 100% required?
So to clarify, for IH, the MSLT is not a bad test. In IH, all you're really documenting is how sleepy someone is. And the MSLT is pretty good at figuring out how sleepy you are. What its challenge is that it doesn't always figure out, or people don't always go into REM sleep in these naps, even though they may have narcolepsy. How do you change it? That's a really interesting question. The changes happen at an organizational, the American Academy of Sleep Medicine, that actually comes up with the diagnostic criteria that I showed, the ICSD, the International Classification of Sleep Disorders. There are people who are arguing it. There are people who are arguing it the other side. You clearly understand which side I'm on. Not everyone's of that same opinion, so there are people who feel that this is the right criteria. But there's more and more move afoot, recognizing that the MSLT is a very challenging test.
And I think the most recent change is that if you, on the overnight test, if you go into REM sleep within 15 minutes, that's like, and you have cataplexy, okay, we're done. We're done here. That's narcolepsy with cataplexy. It doesn't matter what the MSLT shows, and that was just something that was recently changed from I think last year. And it's kind of recognizing the REM intrusion as the biggest part. But I've had but it still doesn't help with idiopathic hypersomnia, or even people that they have to stay on, like, so I have a lot of patients that are on SSRIs or other medications. It's just not safe for them to go off of it. And so what do you do in those situations where they'll never be able to go off of a REM suppressing medication? And are they going to be stuck with an IH diagnosis forever? Or do we have to really push a spinal tap to do orexin level testing? But that's hard to get, and also both physically and like logistically. And what if it's still negative but they still have symptoms? And so like I'm stuck with we're trying to treat the patient, not like a test result.
Yeah, the other interesting thing is that if you look at the DSM, the DSM is a psychiatric diagnosis manual. They have a narcolepsy diagnosis there. That definition is different than the ICSD. It is a little more lenient. But no insurance company looks at the DSM. They all look at the ICSD.
Yeah, sometimes I use the DSM as like, and when I'm writing the appeal letter for coverage of the medications, like, look, they meet these criteria. Sometimes gets through, sometimes it doesn't. And it's still something that's evolving and constantly being worked on. And unfortunately, there's no quick solution to find the best test.
I just thought of a second question. If you have two sleep studies and the first one said narcolepsy and the second one said not narcolepsy, but you still feel like you have the sleep disorder and it's still on your chart as narcolepsy, how do you go forward with that as far as, do you have a diagnosis still?
Yeah. I mean, especially with that first one, if it was like clear cut, you met all the criteria, I mean, I would just say, keep that test. Don't repeat the MSLT ever again unless you're really motivated to remove your diagnosis of narcolepsy. And sometimes that happens. Sometimes I've gotten it wrong. I definitely had a delayed sleep phase teenager that he also had a little bit of anxiety, depression. He was going, and his sleep schedule was set to be going to sleep at 1 a.m. and waking up at 11. The MSLT was quite positive. I tried oxybate, didn't work. I was trying a lot of medication, didn't work. I strongly encouraged him to go to therapy, and he worked on himself. He got better, and he was on medications for 6 months, without medications for 6 months. He told me he was not sleepy, and so I had to say, okay, we can you don't have narcolepsy. We did MSLT was negative, and so okay, we can. But I wouldn't say that for someone that's still complaining of excessive daytime sleepiness, especially when they're not on medications. That it's like there's no reason why. There's no question I'm trying to answer. There's no motive there's no reason why I would to repeat the test. And that's a strong recommendation I give to a lot of my teenage patients as they're graduating, is that you have a very strong result and don't repeat the test. The only time you need to repeat the sleep test is maybe for an overnight sleep study to make sure to see if you have sleep apnea or not, because that can still happen.
Thank you.
All right. So first of all, thank you both very much for coming here today. Really appreciate all the good information. And Dr. Ortiz, real quick, as a follically challenged individual, just to answer your poll, you are rocking that long hair. So don't change that for a second. This is a really nerdy question. I think this is directed towards Dr. Husain, but whoever wants to answer it. Can you give me any more feedback on the use of how you're using AI now, not just in the diagnosis, but potentially the effectiveness and the analytics of being able to research and diagnose narcolepsy? Because I think of how there's 50 plus million fitness trackers out there tracking every movement, right? And I think you used it in some of your presentation about how you can really clear cut kind of catch some folks with that. And if you have 50 million trackers out there, you can collect all that data, all that analytics, then you could have a diagnosis of millions of people, right? And that greatly improves the pool of folks that might be diagnosed, which greatly improves the marketplace, which greatly improves the research funding and the potential treatments that go into it. Can you talk a little more about maybe what you know as far as any type of AI or more analytics that you use to diagnose that?
Yeah, it's really primitive right now. We are just scratching the surface of it. There's a lot more to be learned. I mean, an example of what you just talked about is the Oura Ring. That's one of the most common type of daily trackers. They recently published their data on several million days of monitoring for hundreds of thousands of people around the world. And it's just very interesting to look at sleep patterns around the world, in the US and developing countries and Europe, and just how people sleep differently. Imagine taking that for people who have narcolepsy and analyzing that data. I mean, I showed you some of the work being done that looks at sleep stages just in the overnight sleep study, and how drastically they're different, and how easily you could get to a diagnosis of narcolepsy rather than going through an MSLT and other testing. And so, is that happening now? No, it really will require another maybe 3 to 5 years for this to start to become mainstream. And this is not being applied in the clinics at this point, not that I'm aware of. It's really at a research level. So I think hopefully quick, but can't come fast enough, I think.
So AI on a clinical way, I don't have much input, but as a person with narcolepsy, AI has been so much helpful for me in terms of living my day-to-day life. So my health system adopted an AI scribe that basically listens into the conversation that I have with the patient and listens to when I say I examined this part of the body, this is what I found, and it writes my notes. It literally offloads so much like effort and work. It's basically like, if you think that, you know, at the end of the day I have all these notes to write, that's like 2 spoons. Like sometimes it's like, it's, you know, the last thing I want to do is write these notes, and I just am dreading this because it's going to sap the last remains of my energy for the day. And then, you know, if I leave it be for the next day, I'm like, what? This is nothing. Like, it's done. But like when I'm sleepy or tired, it's like I can't imagine doing this. But then you get in trouble because the work starts accumulating. This offloads all that work, and it takes what maybe like an hour task down to like 10 minutes. And I think that using AI in other ways for some of these mundane tasks, like recording a conversation and like a meeting, recording a meeting, breaking it down into what you need to do. There are a lot of apps like that, like Otter AI. That I think it might be a good tool for people with narcolepsy, because it really offloads some of the mental effort you need to exert on yourself to get some of this like mundane tasks done. And I'm a big believer for some of these uses. So writing letters or reviewing what happened in a meeting, it helps. And I think it might be a task that a thing that everyone should kind of look into to see if it would fit into their lives.
Hi, so I have a question about, I think it's sleep cycles. So essentially, I also have delayed sleep phase syndrome on top of with the narcolepsy. And I also am someone that experiences a lot of sleep inertia typically, probably because of that. And so what I'm wondering is, I noticed that, well, based on my sleep doctor's recommendation, I don't change my wake up time more than 15 minutes at a time. And so typically when I have to change it and I'm tweaking it, these little 15-minute increments, I'll find all of a sudden, oh no, I went past where I wake up easily. I'll find a little increment of time where I wake up and it's without sleep inertia. Is this due to somehow me entering another sleep cycle or something, or is this a real pattern? I feel like that kind of works for me, but I don't know how else to explain this.
So a lot of it has to do it does depend on what phase of sleep you're in. So stage 3 is considered deep sleep. It's the toughest to wake up from. It's considered painful to wake up from for some people, and it's also one of those it also is one of the reasons why when we recommend people to take naps, to keep it short, because if you keep it short, 20 minutes, you're less likely to enter deep sleep. Because if you do it longer, the chances of you entering deep sleep increases, and it's a lot harder to wake up from. You feel worse than when you initially woke up from. And so that might be the reason. You are timing yourself to wake up at the wrong time, and that's why it's difficult to wake up at certain periods in the morning. And I think someone mentioned the sunrise lamp. I think that's also another tool that can be helpful in terms of kind of working against the sleep inertia, because it's the light can cross through your eyelids. It's going to start alerting you, and it's going to be gently nudging you away from a stage 3 sleep. Stage 3 sleep is typically more towards the beginning of the night, and so if you're doing some kind of like environmental signaling that it's no longer nighttime, that can help your brain shift away from the slow wave sleep.
Awesome, thank you.
Thank you. We have a question from our audience, if you will. Any recommendations about how to navigate the seemingly endless drug shortages on meds like amphetamines, etc.?
Say that one more time.
Yeah, it's any recommendations about how to navigate the seemingly endless drug shortages like amphetamine, amphetamines. Thank you. Sorry.
Unfortunately, no great strategies. Having multiple pharmacies, or finding. I've often had people tell me that they have one particular pharmacy that they go to that seems to be able to source their drugs, but I don't have a great.
Same thing. Like sometimes it's like they alternate. I have some patients that just alternate between 2 different pharmacies. They're like usually 2 different chains, like CVS and the chain, the one for their grocery store chain, and they just alternate between the two. Or like there's always just one that will have that, they know that they will always have that medication, and so everything else gets sent to one pharmacy, but then their stimulant gets sent to this one. There's no good answer for this. It's more about collecting a list of pharmacy phone numbers, and just when you're running low, and that's also a thing, like don't wait with the shortages. Before the shortages, I would say call a week before. Now with the shortages and you're not sure if one pharmacy will have it, I would say 2 weeks before you're due for a refill, you start calling the pharmacies up to know where you want the prescription to be sent to.
And the challenge with that also is that these are controlled substances, and many pharmacies will not refill it until you're actually the day that you run out. So lots of challenges, unfortunately, no great solutions. If you're in a state that allows it, get a 3-month supply.
So I have a tip on that. I take dexmethylphenidate, and instead of getting the extended release, I take it 4 times a day, and I never have a problem getting my refill. They always have it.
Okay.
I sort of asked this question this morning, but so I do not have narcolepsy, but my daughter does, and I'm trying to get a handle on the medications. And I could be wrong, but I think you're trying to move away from like the stimulants like Adderall for the newer medications. I might be wrong about that, but I'm trying to understand why that might be, and also because this will be a long-term medication use, the side effects of long-term medication use on other organs, on other parts of the body, like, are there risks with that? Obviously, these may be risks that we obviously have to take, but I was trying to get more understanding about these kind of issues.
Yeah, I'll start, and maybe Dr. Ortiz can jump in. Are we discouraging older medications? I'm not sure that I necessarily agree with that. I think the newer medications give us more options. For some people, they're more effective. For a lot of people, they have fewer side effects. So in so much as one of those applies to you, then yeah, the newer medications are better. If none of those apply to you, then older medications may be fine as well. Generally, as you get older, some of these older medications have more side effects. So as you get older, there's a greater risk of having blood pressure problems, palpitations, and things of that sort. So I think that we're not necessarily getting away from them. I have a lot of people who still take Adderall and Ritalin and so on. But the newer medications offer us different and better treatment paradigms. I mean, many of the folks complain about sort of the ups and downs, the cyclical nature of how you feel better, but the newer ones are a lot smoother. But when I've tried to transition people who've been on stimulants for a long period of time onto some of the newer medications, they feel they're not as effective because they get that sudden burst, and then you don't get that with the newer medications. It's a much smoother ride. So if you've not experienced that, then this is fine. The smooth ride is fine. But if you've experienced it, it may not. So I don't know necessarily that I would agree with that we're trying to get away from the old medications. But they do have more side effects. But if you don't have those side effects and it's not an issue for you, then that's not really the case. But as you get older, there's more and more of a risk of that becoming the case. Also, one of the things I said earlier on, just because the newer medications are so-called big guns, that doesn't mean you don't try them now. I mean, you want control of your symptoms the best that you can. You don't want to just be okay. Are you okay? Are you getting by? Yeah. Could you be better? Definitely. Why not shoot for the better?
I kind of lost track of all the people that had questions, so if you can raise your hands again. So 1, 2, and 3. Okay.
Just super quick, are you able to take both? Like if you're on an amphetamine now and don't really want to get off of it just because you don't necessarily have a time window to lose a couple days of work, could you take both at the same time?
Which both?
Like both amphetamine and then also an oxidate.
Certainly.
Oh, yeah.
Oh.
Yeah. Well, I feel like with my personal philosophy is whatever works, we'll do it as long as it's safe. Granted, like if we're getting up to like crazy high levels of amphetamines or methylphenidate, we're gonna have to start having a talk about switching to another medication. Or sometimes it's like, oh, you're on these 2 medications. I don't see any. If there's no conflict with that, then and you're doing great. There's no law that says you can't be on that. There's no rule that says you can't be on it. And like our job is to make sure you're doing this safely. And as long as we don't see any danger or warning signs of danger, we're gonna stick with what works. Or I'm gonna stick with what works.
Dr. Ortiz, earlier you're talking about circadian rhythm. Years ago, my daughter was in Japan and had a baby, and we flew over there. That week that I was there, I was the most awake I've ever been. Was it that, or was it just the dopamine from seeing my new granddaughter?
Oh, that's a tough situation. So like circadian rhythm. So basically, it takes a few days before your circadian rhythm shifts over, and usually people experience something called jet lag, where they just don't feel well because you're actively working against your circadian rhythm. And so I'm not sure, like sometimes people with a delayed sleep phase, they may feel good temporarily because they fly over to a time zone that kind of actually aligns with their current circadian rhythm. But you're right, at the same time, you're probably like having you probably were having a dopamine rush as well with meeting a new grandchild and excitement. I mean, that's kind of like how I deal with my daily sleepiness, because I kind of get animated and excited when I talk about sleep. So I see patients all the time, so I'm kind of active. And then as soon as I'm done seeing patients for the day, I'm like I deflate because now I no longer have this like kind of like reinforcing stimulus to keep me awake. And then and I also hear that from other parents of kids with narcolepsy. Oh, as soon as if they're in school, they're like that, and like it really takes. And sometimes it's like it really takes them a long time before they fall asleep playing video games, unless there's like a lull in the video games, because video games are very self-reinforcing. They're constantly giving you a stimulus that gives you a dopamine rush, and so you're actively and so it's tough to say. I don't think the circadian rhythm shift was affecting you, but more of what was going on in front of you.
Hold on, let me get my notes. My memory's not good. Okay, talking about the medications. So I'm not on many medications just because of side effects and everything. So, but I'm at the point I want to try something else. First, I had a comment about someone asking about running out of meds. I have a friend who has their doctor write them for double the prescription, but they only take it once a day, but it's written for twice, so maybe that would help. And then also the medications that are out, because I think this is part of my barrier too. So I can only take meds from certain manufacturers because of my allergies to gluten and dairy. So are these meds that you guys talk about, is it just the one manufacturer that makes it? Are there multiple manufacturers? Because that's part of my barrier too, is I can only take certain manufacturers. People don't always like to fill my meds.
I think with the newer medications, there's just going to be one manufacturer. So like pitolisant, Wakex, the oxybates, Sunosi. I think correct me, like we have people representing these companies here. They might have better answers for it than I do. And usually these are coming from like a centralized pharmacy. So it's only going to be like one or two pharmacies that are going to be delivering the medication. So I think maybe touch base with the people at the tables and they'll probably be able to they may not have the answer for you, but they might probably be able to get it for you.
Okay.
Sorry.
No, it's my life.
Hello. Sorry, I have a quiet voice. I started having my symptoms of my sleepy disorder when I was a teenager, and I was started on an SSRI, which helped a lot, and started on Wellbutrin, which also helped a lot, but I struggled through vet school and graduate school, and I really can't go off my SSRI, but I've never gotten an official diagnosis, so right now I'm just IH. But I tried to go off of my SSRIs. It gave me really bad restless leg syndrome, and during my sleep study, I couldn't sleep. And so I got a lumbar puncture, and my orexin came back not low enough, but low. And so I don't know, I'm just wondering, like, do you think I'll be stuck forever without a diagnosis? Or, I don't know, what path forward do you recommend?
So have you ever had the whole like testing while you're on SSRIs?
No.
Okay, so I would do that. And so at least having the diagnosis, so I've had patients who were on, they would have had other reasons for being sleepy, but they're also being treated for it. And some of these medications also would have created a false negative, but they ended up being positive. And so if you end up being positive while on the SSRI, I would, there'll be no doubt that you do have narcolepsy. And even if you have like a positive for IH, that still allows you to move forward with certain treatment options. And so I would, if you were my patient, I would just advocate for doing the evaluation while on your medications. And sometimes we just have to accept that because, like I said, we can't let perfection get in the way of good. And although I'm really suspicious, the low but not diagnostic level of orexin is a little sus, and I would have, maybe I could have, your sleep doctor could maybe try to spin that with the insurance companies to get started on treatment and just saying, this is weird, and you meet all the other clinical pictures for it. This is just kind of adds an extra layer of proof that it happens. But I think I would still advocate for doing the MSLT while you're on the SSRIs.
Thank you.
My question was, I just wanted to know what is the youngest patient that you, Dr. Ortiz, has helped with narcolepsy? I'm asking because my daughter was diagnosed, she was age 4 and she just turned 5 now, and so a lot of the medication that is out there for her it doesn't start till 6 or 7. So we started gabapentin at night. That's not doing much. And so I'm just wondering what you would recommend as other options for the nighttime sleep. I think she has REM disorder because she does talk and act out her dreams every night. And then she's sleepy during the day, but I let her sleep because she's young.
Yeah. So I have some patients that were diagnosed that young. They weren't my patients when they were diagnosed that young. I don't have active patients that are this young, but I do know of them. And I think of it, what happens in that situation is that we have to just advocate for like a compassionate use for oxybate. I definitely know of 4-year-olds on oxybate that they have confirmed narcolepsy. We would start it, and fortunately there is, for the oxybates, there are like dosing based on weight, which allows us to kind of modify it based on how big they are. I would probably, just because of the respiratory, like pediatricians are a very cautious bunch, and so I would probably just do a sleep study. This is my just thinking about it, like an overnight sleep study while on the oxybate, just to see what his breathing's doing on the recommended dose, and advocate with the insurance company to get it started. Just because it may not get in the way right now, because 4 years old, preschool, there's no big academic requirement for them to stay awake. It's expected for these kids to take naps anyways. But once they start kindergarten and above, you want to be ahead of this before it becomes a problem. And that's what I would start off with that, and with the oxybate. And then once once your child's 6 years old, then we can start trying the stuff for the actual approvals.
One more question over here.
So, as someone who doesn't have it, I read a lot about it for my wife, but everybody happens to realize later in life, right? They're always really born with it. Can it happen to anybody? Is it a specific type of person that it happens to? And if so, is there any real hope for turning that light switch back off? Because it's obviously happened for a specific reason on a specific person.
It can absolutely happen to anybody. There's a greater risk. Narcolepsy certainly can run in families, but it can happen to anybody. The classic incidence quoted in literature is 1 in 2,000 people are going to get it. It could be any one of those 2,000 people. I think it's probably a little bit higher. As to whether you can turn off that switch that's been turned on, or turn it on that's been turned off, what you're alluding to is sort of what I mentioned at the very end. Transplant therapy, transplanting brain cells to bring those hypocretin-containing neurons back. We're not there yet. People are working on it. That would be sort of the way to fix the problem. And at this point, we're treating symptoms. Some of the newer medications that are orexin agonists, they actually work on the orexin system and make it better. Certainly for the type 1 type of patients, that seems like that's addressing the problem a little bit better. Whether they end up being superior to all other medications remains to be seen. Every time a medication comes out that's going to be so much better, it unfortunately ends up not being that much better, but we'll see. I mean, we'll have to wait till they become available.
Yeah, like studies have shown there's no like preference for male versus female. Age groups, there are like 2 age groups, like between like adolescence and then mid to late 20s, but it can happen at any age. There's no race that is like it happens more often than others. It's something that happens to you, and so and that's still the reason why it happens to you is still being looked at. We already mentioned that there's an autoimmune component, especially with type 1 narcolepsy. So it's like an immune response. Something happened to you, your immune system responded to it inappropriately, and then you have narcolepsy, at least type 1. But with the other disorder like type 2, IH, it's still unknown.
It actually is more common in Japanese individuals, so if any of you are of that heritage, slightly more common.
Slightly more common, yes. And there are some genes associated with an increased risk, but it's still not like you can be negative for these genes and still develop narcolepsy.